Okay, perfect. So thank you very much, Brenda, and I'm really happy to be here today. I'm assuming that most people in this room are not tuberculosis experts. That's why I thought that we would spend the first few minutes just really emphasizing why this is so important. Because this, we'll be going really into quite a detailed project here in one particular component of TB. But I do think it's important. It's an example of a very significant global health public crisis that this example in TB we could expand to other pieces of TB, definitely, and other communicable and infectious diseases. So like Brenda said, I'm from USAID. We are based in Washington. We have a team of about 25 people working on international global TB. I have a colleague here, Kendra Chittenden. She works with TB with our Asia Bureau, so it's good that she's here and can also chime in at certain points. So I just wanted to emphasize, I think a lot of us are working in a developing world, so this probably isn't a surprise. But just to reiterate that tuberculosis is in fact the top infectious disease killer. And I think sometimes this does surprise people. I think people sometimes think HIV/AIDS or they think malaria. But unfortunately, no, TB gets that great distinction of being a top infectious disease killer. What's unfortunate about that, in the fact that, other than the fact that it's killing people unneedlessly, is that we are the least resourced of the three big infectious diseases. For example, within the funding envelope for the Global Fund, TB receives 18% of the funding for Global Fund, with HIV being, I think, 50% and malaria rounding the rest. So there is that challenge that we are faced with. Even within my own agency at the USAID, TB is the least resourced of those three diseases as well. So it's increasing every year, but still it's vastly nowhere near where we need to be. This is why partnerships with BD and with others is so incredibly important. Just to give some more perspective here, I don't want to bore you with numbers, but last year, 1.5 million people died from TB, including 250,000 people, 250,000 deaths among people with HIV. I think also what's really important for people to understand that TB is the major cause, or one of the major causes, if not the major cause of death due to antimicrobial resistance. So talking about antimicrobial resistance, multi-drug resistant TB, this is even a greater public health crisis than just TB in general. TB is curable. You have to take 6 months of medicine and treatment. It's not great treatment. The drugs aren't great, and you have to take a lot of them. But if you get TB, most people will get cured. The problem is that when we do have the multi-drug resistant forms, the ability to treat people drops dramatically. People's lives are incredibly changed because treatment is 18 to 24 months with very damaging, very terrible drugs. One common side effect of the treatment is hearing loss, and that's permanent. So even though we do have strategies, we do have treatment, we actually have gotten some new drugs in the past couple of years, it still is nowhere near where we should be in 2019. This graph shows the real issue here. This is the treatment outcomes, or the people that have been cured starting treatment for MDR-TB. 2009 is at the top, and the green are the number of people that have been successfully treated. And you'll see that this number really, even now, is hovering still less than 60%. We're hovering like 55%, which is absolutely unacceptable. And I think what's really troubling is the numbers that are dying in red and the numbers that are, the failures that are in red and the people that are dying in orange. It's figuring out, are these people so sick when they come that you just can't treat them? Or are they okay, but we're giving them the wrong treatment? And the whole basis for this talk, since diagnostics and laboratory is my specialty, not treatment, is that we're not actually treating the right disease, probably. I think that we're assuming a particular drug resistance profile, and we're doing this for a number of reasons. Throughout history, or throughout the last couple of decades, there has been, I think, a conception that strains of TB, strains of multi-drug resistant TB, stay within borders. So if you normally would have had a particular strain of TB that is resistant to a certain pattern of drugs in Asia, well, then everybody must have that profile, and so that's how we treat them. But we know that's not the case. And so thinking about that in an epidemiological way is no longer valid. And the only real valid way to be able to appropriately treat someone with MDR-TB is to know their exact resistance profile. And the advocates and others have pushed for this, always. But it's always, but it's been the people who are running the TB programs. It's people who are looking at this from a practical standpoint that realize this is a very difficult thing. And if we were to not treat someone until we had that profile, no one would be treated, people would be dying, because of the fact that we have very poor, I shouldn't say poor, we have not very efficient ways to diagnose because of the fact that the Mycobacterium tuberculosis is such a tricky little bug. It grows very slowly, and it just continually evolves. It continually acquires new resistance. It's just very difficult to have developed good drug susceptibility testing for TB. The other thing that's going against us is that the infrastructure in countries that need to have access to testing is very poor. And it's been difficult to get specimens from people who have TB in one part of the country to a centralized lab that has the ability, that has the biosafety level 2 or level 3 laboratories to be able to do this testing. So there's been a lot going against us. And just one other thing, I'm sorry for the busyness of the slide, but I think it is very key to what we're trying to get across here, is the complexity of the treatment regimens. So what this is showing us, and like I said, we've had a couple of new drugs coming in recently, bedaquiline and delamanid, which is fantastic, but it has changed our thoughts around treatment. So here, I don't want to get into any of this, but the purpose is basically showing that in the second column are all the different drugs that a person could potentially be prescribed for multi-drug resistant TB. And unfortunately, there isn't one way that we can test all of them to determine what their drug resistance profile is. There are two categories. There's phenotypic DST, that's using either liquid or solid culture, or molecular DST, which is line probe assay or sequencing. And several years back, WHO came out with some very strong policy saying that we should be focused and we should be only concentrating on molecular DST because it's quicker. We just think it's the way we should be moving forward. Well, back then, the treatment regimens made sense because a lot of the drugs that we were using for MDR-TB, we could actually test them using molecular methods. We knew most of the drug resistance, we knew the mutations, and we were able to do that. Not anymore. And so this is what I'm trying to show here, is that if you look in the last column, it's really only the first category of drugs, the Levo and the Moxi, where we can use molecular DST. The other ones, we need to go back to doing culture, using solid or liquid testing. And so, we kind of keep going back and forth, and, I do feel bad for countries because, one day we'll tell them, okay, do all of your resources to this type of testing. Okay, well, oh, wait, stop doing that. We need to go back and do the other form of testing, and countries just aren't exactly sure where they're going. You'll see sequencing here is shown, but honestly, it's still theoretical. We don't have sequencing capability or capacity in any way in these countries to be able to do this. So it's kind of, we're working towards it, but realistically, what we have in countries to work with are our culture testing things. So this is kind of where BD comes in. Many years ago, there was a project that was UNITAID funded that capacitated labs in developing countries with line probe assays, with basically the capacity to do liquid culture or to do line probe assay. And that was great, but then the project ended and the money stopped. And those labs are now sitting with these really nice big paper holders, I guess you could say, right? Impromptu desks collecting dust. And it's really unfortunate because it's there, and most of them work. Maybe they haven't worked in a while, but the problem is there's no staff that know how to run these instruments. There's no updated SOPs. there isn't the capacity to do this. And so, there's also been this concern about going back to a non-molecular based test because of the turnaround time. But if it's having a result that might take a few more days or having no result at all, it's not the best idea. It's not the best solution, but it's a good solution and it's available. And so, what we were, from our perspective at USAID, we saw that there was this available equipment, there was this potential. We knew that it was a really good test, but there just didn't seem to be interest by the country or capacity or interest, frankly, by other, the company itself or others to really think about how we could get this, up and running until maybe sequencing became more of a viable option. So that's kind of the background. I know that was a lot of information for why this is really important to us. But I think, the real thing and what we are very concerned about is that we still in 2019 or 2018 have so few MDR patients that actually have this full drug resistance profile. Even in India, where we have probably the most capacity, we have the most labs, only 2/3 of the MDR patients actually have a drug resistance profile. And India is responsible for 1/4 of global MDR cases worldwide. Indonesia, 28%. Nigeria is 83%. I question that, and I think it might be 83%, but probably the quality is pretty poor. My Nigerian colleagues, I apologize. Philippines, I think everyone is pretty surprised at such a low number. And even South Africa, which for the TB world has probably the best ability to diagnose first-line and second-line drug resistance, we're only talking about half of their patients. So here we have an entirely huge population of patients that are being given treatment, new drugs, remember, and they could be given a treatment that's not even going to do anything for them. So on one hand, that's horrible for the patient, right? Because the chances of them surviving is very low. And the second thing is it's really bad for the community in general because we have these new drugs and they're going to quickly become resistant. They're not going to be available for us to use. So unless we do something now, we are going to be going backwards very quickly. So I just wanted to have 2 last slides here, just to give just a little bit of background, with the USAID and, talking about how we do this and kind of what's happening at that, the more global WHO, UN level. So we have this, what we call the Accelerating Action on TB towards achieving 40 by 22. What we mean by 40 by 22 is that we need to find and detect 40 million cases globally by the year 2022 in order to start seeing significant advances, or I guess you could say decreases, in the tuberculosis epidemic. And USAID is the international lead for TB for the US government. We have bilateral priority funding for 23, 24 countries. These are the largest countries. We are providing services that range from prevention, diagnosis, all the way to treatment. But our team and a lot of what we're pushing in countries is really about the diagnostic piece. If we can't diagnose the case, treatment matters, but it's really about the diagnosis. And then the last thing I just wanted to pull up, because I think it's important. USAID, and especially in my bureau, the Global Health Bureau, we've been working with private sector partners for a long, long time. In TB, I know of several, and I know my colleagues in all the other diseases and all the other areas have been working. But what's interesting about this is that our administration has just recently I think, written it down, like defined it, and actually has made it a priority, which I think is incredibly important. So, I would encourage all of you to, check this out. There is a link there. You can definitely share that wider. But I think that this is going to change. I think a little bit about how we engage with private sector. I think it's going to bring a lot more value. We as individuals and what we're doing in our particular areas find incredible value in it. We just need to make sure that everyone else, within the U.S. government and within our countries, see this value. So let me stop there, and then I know Renuka will kind of take over to say, like, from this very technical reasoning in this global health crisis, how we kind of came together to do something about it. Thank you.
Thank you, Amy. That was great.